This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV. This Week in Virology, episode 1196, recorded on February 27, 2025. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
Oh, the Parasites Without Borders bow tie. I can see it
with the
here.
world and the Ascaris worm all wrapped around it.
How many bow ties do you have? Like 50?
It's got to be over 100 at this point.
So we're never going to see the same one in a year. Huh?
You know, there are certain ones I realize that I prefer. So I probably have about 50 that are microbes, but I also have a whole bunch of like sailing ties and, I have a bunch of like Mickey Mouse pediatric ties. I've got a whole
Do you
range.
have a favorite microbe tie?
Yeah. What is my go-to? People probably know, like when I travel, like if I'm just going to throw one in there, it'll probably be my, my gonorrhea, the clap bow tie, because it's a bright, sort of.
Okay.
Yeah.
So let's say you're going to Washington, you're going to have a meeting with RFK Jr. What bow tie are you going to wear?
So, as I have done like in certain situations like that, I've got this really nice coronavirus bow tie, and it's sort of a black with a gold coronavirus. It's cool.
Oh, I can hear the conversation. Dr. Griffin, what's that on your tie? And you say, it's a coronavirus. And he said, oh, that doesn't exist. Good.
All right, Vince. So let's get into it. I'm going to start off with a quotation, which, I was looking this up because I've been hearing this, since I was a small lad from my grandmother. So I figured like where, who was the first who said this? So apparently this is attributed to Samuel Langhorne Clemens. Never let the truth get in the way of a good story. So Mark Twain. And unfortunately, this is a quotation for our times, or a lot of folks seem to feel this way. And not to be political, Vincent, but meeting of key CDC vaccine advisory panel under scrutiny by RFK Jr. is postponed. Officials say the session will be rescheduled, but provides no details. And so the Advisory Committee on Immunization Practices was to meet from February 26 to 28, like right now as we're talking. Its first gathering since the Trump administration took office. That will not happen, according to Andrew Nixon, the HHS Director of Communications. There was a notice of postponement posted on the American Committee on Immunization Practices homepage. The ACIP work groups met as scheduled this month, but we still do not know about the ACIP meeting. I do have a link here to the draft agenda where they were to talk about meningitis vaccines, chikungunya vaccines, flu vaccines, RSV vaccines, the HPV vaccines, Mpox vaccine, Lyme disease, COVID-19 vaccines, and CMV vaccines. And this is where they were going to select, like, hey, which flu shot are we going to recommend next year?
That's the VRBPAC, right, at the FDA?
Yeah, so the FDA.
So two important meetings canceled, Daniel. What messages are Americans supposed to get from this? Probably most of them would like to get some of these vaccines. And so what does this mean? That we get no guidance from the administration?
Well, it's tough. I mean, we were told that they're looking for a larger room. People who are not allowed to talk to people told me this, that the excuse they're giving is we want a larger room because what we would like is we would like to have a lot of public there so that when they're trying to have a discussion that the public can, quote unquote, weigh in with loud voices. The challenge here, and this is something I want people to think about. So, we're going to talk about Texas and measles, and you can see 97% of the children there are vaccinated. So, vaccinating children is still a mainstream recognized thing that we do here in the U.S. But there's ways to undermine vaccines, which are a little, I'll say, sneaky. And I think that's the right word, right? So the way that vaccines get covered is you have these meetings, and then the advisory committee goes through the data and they say, this is the flu vaccine and we're going to recommend this and, similar to some of these other vaccines. And then the CDC makes a recommendation. And then, we have recommended vaccines. And then after that, Medicare pays for it, insurance pays for it. If you don't let these groups meet, then there are no recommended vaccines. Quote unquote, we're going to let parents and their doctors make a decision. But what this is going to lead to is that we're not going to necessarily have those vaccinations covered. So when, mom says, yeah, I really feel like I do want to protect my child from, encephalitis and death and all these other horrible things, the next thing may be, yeah, but your insurance isn't going to cover it because we've, sort of undermined the process here.
Great. What a great plan.
Well, it's sneaky is what it is, right? It's, they use rhetoric and the rest, but we'll get.
This is crazy. The federal government with trillions of dollars had to cancel a meeting because they couldn't find a big room. This is the most elevated form of BS I've ever heard, Daniel.
Well, it's disingenuous. This is an incredibly important meeting where we're deciding on, vaccine recommendations. It's that's dishonest, and we'll get into some more dishonesty later on. But I don't think it's okay to just blatantly lie like that. So in the same, talking about what about science in the U.S. So I get these New York Times emails, right, where they give you like what's there to read about in the day. And I read, my New York Times emails early this morning because one of my dogs may have gotten into some stuff that she shouldn't have gotten into. So at 4 something this morning, she was up having a bit of a problem that I actually stepped in. And so, after hopping down the hall and washing my foot and cleaning the floor and taking care of her and being up since then, I was reading some of these. But this I had read a little bit earlier with a completely clean, untinged foot. And so there was a section by Benjamin Mueller. And I'm going to read this. Late last month, when the Trump administration froze government grants, a federal judge said it couldn't just hold back money Congress had agreed to spend, but spending at the NIH, which awards more than 60,000 grants per year, isn't so simple, right? So this is going to be this strain of let's undermine things in a disingenuous, dishonest way. So new grants actually go through as he describes, a tortured bureaucratic process. The agency has to notify the public of grant review meetings in the Federal Register as a government publication. Then scientists and NIH officials meet to discuss the proposals. The problem is that the Trump administration banned these announcements indefinitely, so no new research projects can get approved. So in effect, scientists say the Trump administration is circumventing the court order with this bureaucratic trick. So if you're a cancer doctor, we hope you're happy that we've cracked that nut and you're not really interested in any new treatments or cures. Much like what RFK Jr. is doing with vaccines, you can undermine vaccines, you can hobble cancer research just by stalling this ability to move things forward. You can stall our ability to understand chronic disease. And what you're doing is you're saying, okay, yeah, Congress controls the purse, but we're going to break the system so you can't actually get those funds out there by basically hobbling the bureaucracy.
Daniel, a smart lawyer can get around this. Okay, so that's what they need to be doing. You're obstructing congressional appropriations by doing multiple things. Fix them all. That's it.
Yeah. No, it's really, this is what they did with PEPFAR is they said, oh, okay, we're going to give special letters of exemption. Those HIV medicines can go out there. But there's no computers. They shut down the computers. So even if the HIV medicines showed up somewhere, you wouldn't know who gets what. So they've figured out ways to basically be sneaky and dishonest. So, I'm trying not to be political, but yeah. We have, it's hard to not be political when you have people dying.
Well, it's people's health at stake and also the health of the U.S. science establishment. We have great science here in the U.S. There's no reason to break it. There's zero reason. And if anyone in the U.S. thinks it should be broken, I'd like you to tell me why.
Yeah.
So this is ridiculous.
Yeah. No, I mean, this is part of what makes America great. We are the world leaders, and I'm going to say this, world leaders in science, and have been for decades now. And do we not want to do that? Do we want to let someone else take over? Yeah, it's a problem.
A few individuals have decided that we want to destroy it, Daniel. That's what kills me. A few individuals.
Yeah. Yeah.
All right. But there has to be ways around it, Daniel. We cannot give up.
We're not going to give up, and we're going to circle back. We're even going to get more angry in a few minutes. So, Ebola, I got some good news. We're going to pepper in a little bit of good news, and then don't worry, we'll be back to doom and gloom. As suggested last week, we may have a win regarding Ebola in Uganda. We hear from the WHO that Uganda has entered a crucial 42-day countdown. So what's going on here? So 42 days is twice the 21 days, the maximum incubation period of Ebola, the Sudan Ebola virus here. And so if you can get past that, if there's no further infections during this period, then you can confidently declare that the outbreak is over. So, and I'm hearing confirmation of this on the ground. I was actually able to get to the WHO website, so I don't know what happened before, but all right, polio, a little bit about polio here. The Global Polio Eradication Initiative, GPEI, said on 24th of February, 2025, during the 4th Riyadh International Humanitarian Forum, that Saudi Arabia has formally committed $500 million to end global polio. It's sort of like they reinforced, like, yeah, we said we were going to do that. We're actually going to really do that. But unfortunately, Vincent, I haven't seen that they've updated their thinking. It seems like, hey, here's a lot of money for a lot of more oral polio.
Yes, it's exactly what they're going to do, and it's not going to help eradicate anything because they're just pouring more virus into the environment.
Yeah, it's a little bit disturbing there. All right, now this is where I actually am quite upset. So I will admit I try to be balanced and calm, but this is upsetting because as we're gonna get to in a moment, a child's already died, and so since we get Tuesday and Friday updates from the Texas Health and Human Services, we got this first update on February 25th, and at that point, the Texas Department of State Health Services reporting on this measles outbreak in the South Plains region of Texas, kind of like West-South Texas. At that time, 124 cases had been identified, right? These are like identified, confirmed cases. 18 of the patients have been hospitalized. We're going to talk about that. Only 5 of the cases are among vaccinated. But I am going to say 5 of the cases, like this is starting to be so much exposure that we're actually even seeing vaccinated folks be identified as having cases. But the rest are basically unvaccinated or no confirmation of vaccine. Now, the CDC has said it will provide only weekly updates, right? But then we actually get an update because something really upsetting happened. The first child has died in the Texas outbreak. The patient was an unvaccinated, school-aged child, according to officials. As we learned, most of the cases have been centered in Gaines County, an area on the western edge of the state. It's home to thousands of Mennonites, which they describe as an insular Christian group that historically has lower vaccination rates. And officials said that the child who died Wednesday had lived in Gaines County. The last pediatric death in the U.S. from measles was in 2003. It's been 22 years since this has happened. We read in an article here in the measles book published by Children's Health Defense, the anti-vaccine nonprofit founded by Mr. Kennedy wrote that measles outbreaks have been fabricated to create fear, leading government officials to inflict unnecessary and risky vaccines on millions of children for the sole purpose of fattening industry profits. Now, for context here, for every 1,000 children who get measles, 1 or 2 will die. I'm going to say acutely in the first couple weeks, this is according to CDC data. But I was just re-listening to Immune 26, there's a lot more to measles, right? So there may be one or two who die in the first couple weeks. There may be 20%, we're actually seeing 40% last year of children end up in the hospital. But the virus also harms the immune system. So you actually see another increase in mortality with these secondary bacterial infections that are going to occur like after the first 1 or 2 weeks. You're also going to see an increased risk of death in the 2 to 5 years afterwards, because you take these kids and you basically wipe out their immune system for a while. So a 2015 study estimated that before widespread vaccination, measles may have accounted for as many as half of all infectious disease deaths in children. And even now, right, the consequences can be serious. So I'm going to leave in a link here because I don't want, us to be saying, oh, this is what RFK Jr. said. But I'm going to leave in a link where you can actually watch RFK Jr. speak at the cabinet meeting. Head of HHS, so he says he's on top of this. So he says 2 people have died. That's incorrect, right? It's supposed to be head of the HHS. He tells us he's on top of this. He doesn't even know how many children have died. Whether it's 1 or 2 for him is, not a problem to have wrong. He downplays the fact that this is the first measles death in, I'm going to say, 20 more years. He goes on to say, it's not unusual. We have measles outbreaks every year. He then acknowledges that children are being hospitalized. But get this, he says that, most of the children being hospitalized are there for quarantine purposes. I'm going to say a comment that needs fact-checking, and let's go ahead and fact-check that right away. Let's go talk to the chief medical office at Covenant Children's Hospital in Lubbock, Dr. Lara Johnson, who says no. The children who were hospitalized were admitted because they were having trouble breathing. They needed supportive care such as supplemental oxygen. And I quote from Dr. Johnson, "We don't hospitalize patients for quarantine purposes."
It's unbelievable.
It astounds me. Here's the head of HHS who told Cassidy under oath a bunch of stuff. And here, it's only been a couple of weeks. Like normally when you have an outbreak like this, when things are getting out of control, the CDC comes in, they help people get up to date. How do we provide the best care? How do we talk to these, people in these communities? When we had that issue with polio in upstate New York, people who normally wouldn't vaccinate said, okay, this is different. We're going to jump in. But already one child has died, and this man's only been in this position for 2 weeks?
What really bothers me is he said, we have outbreaks all the time. Well, in fact, we don't when we're vaccinating people. Most of the country doesn't have outbreaks. In fact, when the vaccine was introduced in the 60s, there were hundreds of thousands of cases a year. Those slowly went down. By 2000, it was declared eliminated. There were no more outbreaks until the Wakefield business started getting parents not to vaccinate in the U.S. So he's wrong on every front. He doesn't read anything. He doesn't study. He didn't come prepared to that meeting. He doesn't know anything that's going on. I mean, can we get rid of him in some way?
I mean, I'm sort of hoping that how many children will have to die before the president says, listen, you can't do this job. You can't have children in the U.S. dying of measles, and the person who's supposed to be protecting our health, the senior person where the buck stops, not thinking it's a big deal. So, just to remind people that, measles is bad stuff. There was a thing on his site, I think we talked about it last week, hey, how come no one talks about the good side of measles? There's no good side of measles. Kids get infected. They are incredibly miserable if you've ever taken care of a child with measles. I posted in this nice measles symptoms timeline that I got from a Substack from Dr. Emily Smith, great Substack, just talking about what goes on, how the kids start off with cold-like symptoms. Then they develop the famous Koplik spots. Then they get the rash. And then you start seeing pneumonia, ear infections, diarrhea. Some kids go blind, ear infections. Some kids go deaf, encephalitis. And then even years later, you can have this subacute sclerosing panencephalitis, which, 100% mortality. I mean, this is horrible. And as I mentioned, it wipes out all that immune memory that you've earned, all that natural immunity, all those vaccines, everything. 70% of the antibody repertoire is wiped out with one measles infection in someone who's not vaccinated. And I do want to point out just that this is still a fringe. This is still a fringe thing, right? So we have a nice table here. Maybe Dave will have it up for folks. That, if you look at the different vaccines, you look at, diphtheria, tetanus, icellular pertussis, hepatitis A or B, the MMR, polio, the chickenpox vaccine, the percent completely vaccinated is actually quite high when you look at Texas kindergartens. And then if you actually look at the state, I mean, we're 94, 95% and above, but then there are these pockets, right? Yeah, and we see pockets. And so really there are these communities where we don't have that. And one of the problems, like, why do we care if your kids are vaccinated or not, is this is an incredibly contagious disease. And so, think about all those children under the age of 1 who are not old enough to get the protection. We're putting them at risk. Think about pregnant individuals. They're at risk. So, yeah, this is one of those things. Your freedom to wave your arms ends at the tip of my nose. Your freedom to, spread a deadly disease is something that we really have to talk about when we live in a community.
I remember what I was going to say. There are pockets of unvaccinated kids here in New York City, right? It's the same everywhere, and it's just a matter of the virus being introduced in them, and then you will have an outbreak.
Yeah, I mean, we had that outbreak in a community in Brooklyn not too many years back.
Yeah, so. That's right.
Yeah. All right. Very, very disturbing, very disturbing. And, maybe people need to see those, those little kids, like, struggling to breathe, being brought into the hospital, when RFK Jr. seems not to actually care. All right, bird flu. A few things here. And maybe there's some good things here. Maybe we'll see. So I thought the first article, will the egg shortage affect flu shots? Is a little encouraging. Millions of vaccine doses are made using chicken eggs each year. And this is actually a nice article where they really go into the fact that there's a whole biosecurity around hens and egg production. And then even if that fell apart, we have other options like recombinant flu vaccine, flu block, and the cell-based vaccine, FluCellVax. So I'll leave a link into that. This was an opinion piece in the Wall Street Journal. I'm going to do a couple Wall Street Journal ones here. Which came first, the chicken slaughter or the egg shortage? I thought that was clever. And here they discuss options, including vaccinating the hens. But really the thing I want to point out here, and I think people just, when I hear people talking, I don't think they understand highly pathogenic avian influenza. If chickens get infected, if your flock of hens get infected, 90 to 100% of those birds will be dead within 48 hours. And it's a horrible death for those birds. So many of the veterinarians, when they're talking about these, killing the chickens en masse, part of it is gassing them is just that it's just inhumane to let them suffer and to have this almost 100% mortality. I'm going to leave in a link to the CDC page, Avian Influenza in Birds, Causes and How It Spreads. And here you get that reference to that 90 to 100% mortality. And they actually go through a lot of, I'll say, sort of important information. But they do talk about the fact that, what's happening is that 90 to 100% of these chickens are going to die a horrible death within 48 hours. Now, the ducks that are flying over and spreading it, they're actually usually doing pretty well. They don't actually get particularly sick at all. So some wild bird species seem to be able to get infected with these particular, say highly pathogenic in chicken virus subtypes, but they tend to spread it. So I think it's important to understand the disease. Before I heard a news commentator saying, well, maybe, we just need to let the hens just all get natural immunity.
Brilliant.
Yeah, wasn't that brilliant? Yeah, we just
brilliant.
Let our hens, let our little girls just develop that robust, wonderful natural immunity. I don't think they've ever seen a group of hens get avian influenza. It's horrible. It's horrible, and there's lots of suffering. But we do have, and I was impressed by this, Agriculture Secretary Brooke Rollins has a 5-point plan to lower egg prices, And I'm just going to run through this, and I'll leave in a link. So first, dedicating, are you ready for this? Up to $500 million to help protect U.S. poultry producers with gold standard biosecurity measures. They actually create a way to protect the birds from those introductions, right? So, when you're entering or exiting where the hens are, you put on special suits, you wash stuff down, you create these barriers to keep the ducks and migrating fowl away from your hens. Second, is providing up to $400 million of increased financial assistance to help the farmers whose flocks have been affected. So help them get back to safe operations after an outbreak. And this was shocking, Vincent. Third, USDA is exploring the use of vaccines and therapeutics for laying chickens. They say, well, vaccines aren't a standalone solution. We will provide up to $100 million in research and development of vaccines and therapeutics, saying this should help reduce the need to depopulate flocks, right? Because if your hens are vaccinated and then they get an exposure, you're not going to have that 90 to 100% death, or 100% if we continue to humanely address this. Fourth, they say they're going to take other actions to lower the price of eggs. I think they're going to remove regulatory hurdles. And actually, if you look in closely, what they're going to do is, like right now, there are rules like, come on, these are animals and they should have at least a certain amount of space around them. And they're like, you don't need so much space. Cram them closer together. The chickens don't need to be happy. We just need those eggs.
Great.
Yeah,
then we'll get one egg per chicken. Just great.
That just bothered me. Yeah, it was like, listen, I think we're being too nice to the hens. I mean, I don't know. Have you ever seen a mass hen, where they burn off the beaks? Okay. And fifth, and this is, I don't think, going to make too many people happy, this idea that we're going to make America great by importing eggs from other countries.
Yeah, I heard we're buying some from Turkey now. Turkey eggs.
Okay.
Daniel, I don't know that this vaccine makes any sense. It doesn't prevent transmission. So it's not going to protect the flock.
I guess what the idea is, it won't necessarily protect spread. But if you always say, okay, we're going to have all our hens in America vaccinated, if the flu gets into the population, now, getting an infection after being vaccinated is much more mild, right? We always say it's not going to keep you from getting infected, but it is going to reduce the disease. So vaccinated chickens don't all die from highly pathogenic avian influenza.
All right, but they still have virus. Maybe it gets into the eggs.
Yeah.
They better just be bloody careful. It sounds like they don't really know what they're talking about.
I'm worried about
this $500 million for biosecurity, I don't think that's anywhere near enough.
Yeah, it sounds like a big number, but just think about, what is it, over 300 million? I think it's like we need 350 million egg-laying hens to sort of meet our capacity. That's like, a buck a bird. Not a lot of money in a country our size.
Folks, give up your eggs and you can blame the administration.
All right. So flu is still really high. Influenza A is still at high levels. Looking across the country, we're still seeing hotspots most everywhere. Actually, even Montana was doing a little better. It was getting into the minimal. It's back up into the moderate. What's really disturbing, right, is that we used to get weekly updates on what's going on. And one of the things I would always look for, because it just seemed to motivate people, is seeing like how many children had died the last week. And this has not been updated since February 7th. That was the week when we had 10 children die. So we don't really get that updated. That's a problem to me, that we don't get the information we would like. But maybe we're coming off the peak. I mean, we're still really high. It looks like we're coming off the peak. Our hope is that we don't get that second hump, which we sometimes get. And I worry, right? Because here we are, end of February, early March. We're going to start to see spring break. So do the kids come home, go back, and do we get like that rebound that we sometimes get when, school vacation timing is sort of associated?
Daniel, what's the purpose of withholding information? Is it to have an uninformed population so they don't know what's happening?
I mean, there's different different reasons why you might want to do it, right? So one is there's the concern that if people think like, hey, things are kind of bad out there, that might affect the stock market, right? Some people like everyone to be optimistic and positive. And if you know that something is going on, then maybe you'll be a little bit, negative or pessimistic. Maybe it'll influence, I don't know, consumer, spending or something. So, the other is that, an uninformed population, it's a dangerous thing for certain
this
people.
Is bad to be withholding information from your constituents. Only bad things can happen. It's going to leak out, and then you're not going to know where to believe it, and it's going to be a mess.
Yeah, and we'll see in the modern world of social media and misinformation. Like, can you keep spinning? Can you keep lying to people? What is it? Lie to me once, lie to me twice, and then the third time. This is also another thing. Like, so we're huge proponents of education, and I know people are like, oh, with the vaccines, there were mandates and they were out there and no money was spent on education. So I was really excited when the CDC had that, I'm going to say, wonderful flu educational series, the Wild to Mild campaign. Remember this, Vincent, with like the lions or the shark turns into a goldfish, the lion turns into a little kitty cat. And I thought it was great because here was really, I think, what RFK had talked about. He wants people to be able to make decisions. He wants them to have the information. And this was really informative. This was, forget about this whole idea that a flu vaccine will mean you never get the flu. It's going to reduce severity. It's going to reduce disease. This was great stuff. Well, the Trump administration yanked the CDC flu vaccine campaign. Now, unfortunately, this is like what's typical. The news was shared with staff during a meeting, and then two of the staffers who were not actually supposed to tell anyone that this was ending agreed to speak, with as long as you can, guarantee my anonymity, as long as you don't tell who's telling you this. So,
It's disgusting that they would cancel a campaign that's meant to inform people about the value of the vaccine. It is just disgusting that this administration does this.
Yeah. Okay, RSV. We're actually still high with RSV. So that's kind of across the board, but maybe a little bit of good news. You ready for this? COVID drop to medium. I was wondering, like, does the wastewater have the ability to drop from high? Will we ever drop? And we're actually seeing a drop in the amount of wastewater SARS-CoV-2. So we're starting to drop. We've got our map here where most of it is kind of moving into the less than 2% of the deaths we're seeing are due to COVID, and we seem to be coming off the peak here with the CDC data on the national trend. So nationally, we're starting to come down.
I don't see our nice chart with all the
colors,
and the ups and downs for all over the country. What happened to that?
You can click on that here. I'm going to paste it in like in real time. Let's go here, Vincent.
So it's still there. We have to click on it.
No, we'll do it because what you're going to see as I paste it in, this will only take seconds, is that it got a little bit busy.
Uh-huh.
Depending on which part of the country. All right, so we're almost to pasting it in. And what you're going to say when I paste this in as I get back to our episode. Are you ready, Vincent?
I'm ready.
Yeah, I see excitement. And maybe this is something that will be pasted up there by David for people to look at on YouTube. So across the country, we're starting to go down. I'm trying so hard to be optimistic. But then you're like, but in the Midwest, it's starting to go back up again, isn't it? So I didn't want to show that.
Well, I'm starting to know if it's going up or if it's just a plateau. Most of them are plateauing, it seems to me.
Yeah. So, see, I'm trying to get the stock market to go up, Vince. Can't keep spreading all this, the bad news, the truth. All right. So now we're going to talk about COVID vaccines. Oh, my gosh. And this is this article. And this is, I thought was really interesting, caught my eye. Effectiveness of the original monovalent messenger RNA coronavirus disease COVID-19 vaccination series against hospitalization for COVID-19 associated venous thromboembolism. So I don't know if people remember in the early days, there was this, it came out of China, don't give anyone anticoagulation because COVID-19 is associated with people just bleeding out. And then so initially nobody anticoagulated. And we're like, what's going on? I remember one day at Plainview Hospital where we did these CAT scans looking for pulmonary emboli in like 20 patients and 15 of them had clots somewhere. This is where we're like, just that's ridiculous. It also, I know it disturbs some of the researchers because they're like, we need to do trials. We're like, we can't do trials when 75% of our patients are dying of these clots. We're going to actually start anticoagulating. Anticoagulation will be our standard of care, and your trial can be deviating from that. We were accused of witchcraft, but anyway, we were accused of witchcraft by these PIs sitting at their home drinking wine, dosing their wives with ivermectin and hydroxychloroquine, but we won't go there. So they use a test negative design to basically say, are the COVID-19 vaccines going to protect folks from getting these deep venous clots? So they look at 18,811 patients, 9,792 were admitted with vaccinations. They got 44% vaccinated. And then they've got a group of these test negative controls. Also with, 73% of those are vaccinated. Now, among the patients, they're going to do all the calculation here. They end up seeing that the venous thromboembolism, these deep clots, were significantly more common in unvaccinated than vaccinated. It's about a 50% reduction, and it varies with the different variants. So you end up, when you do the calculation, you're seeing an 84% overall protection with vaccines. You're seeing about 88% for Alpha, 93% for Delta, and then what drops us down still 68% for the Omicron variants.
Gee, they work.
Yeah, not only do they protect you from severe disease, but they protect you from getting pulmonary emboli and getting these clots. This has really actually changed in a lot of ways our practice when it comes around to anticoagulation in the hospital, where we're usually recommending a prophylactic because we've got pre-existing immunity in many cases from vaccines protecting.
Can people continue to pick on these vaccines, saying they're pathogenic with all kinds of nonsensical data, yet they work?
Yeah, I mean, the problem is, if you actually want the truth, here it is. If you want to support some agenda, some bias, some conspiracy theory, then yeah, you can go get some fake news. All right, early viral phase. Do you remember the days of hydroxychloroquine and ivermectin? They're coming back.
I thought they never left.
Yeah, they sort of went down and then came back. So we have this article, Demographic Variation in U.S. Outpatient Hydroxychloroquine and Ivermectin Use During the COVID-19 Pandemic. And here they use insurance claims from this big database with over 8 million patients, all 50 states. Basically, you know what happened? These two unproven treatments that were touted as COVID-19 treatments during the pandemic, we saw that there was a doubling in the prescriptions for hydroxychloroquine, and ivermectin increased tenfold. And I want to add, we still get people asking for, I need ivermectin for my COVID, or it's really like the son in Florida calling, my dad better get ivermectin for his COVID-19. Or I even had a gentleman recently ask for ivermectin for his heart failure. It's become a snake oil cure-all.
And what do you do?
I have a nice, respectful conversation. I share the information. I've never really had it not work out for them, following my sage advice at the end of the day. But I've just been lucky because I've certainly, been peripheral to some conversations that did not go quite so well. All right. Paxlovid. This is a big one, Vincent. This is a huge trial. I actually was surprised when I saw that this, was being done and came out. But this is a randomized control trial, a phase 3 randomized control trial. The article, Alleviation of COVID-19 Symptoms and Reduction in Healthcare Utilization Among High-Risk Patients Treated with Nirmatrelvir Ritonavir, a phase 3 randomized trial published in CID. Phase 3 randomized trial. We're still doing these. And so these are the results from this double-blind, randomized 1-to-1 study that assessed Paxlovid versus placebo for 5 days in high-risk, unvaccinated, non-hospitalized, symptomatic adults with COVID-19 from 343 sites across 21 countries. Among 2,113 randomized patients enrolled from July 2021 through December 2021, we ended up with 977 getting Paxlovid, 989 getting placebo. The nirmatrelvir, the Paxlovid, significantly reduced two things: times to sustained alleviation by 2 days, so 13 from 15, and resolution, basically completely gone, not just alleviated, not just reduced, but completely resolved. And that was from 19 days, shortening that time to resolution to 16 days, and significantly reduced the number of COVID-19 related medical visits and the proportion of patients with such visits. Now, hospitalized patients treated with Paxlovid, right? So you end up with those, they had shorter stays. None of them ended up in the ICU. None of them required mechanical ventilation. All were discharged to home or self-care. And fewer of the Paxlovid-treated patients required any additional treatment. No Paxlovid-treated patients died through week 24, compared to 15 that died in the placebo group.
Do these, what are the ages here? Do you know roughly?
So they're mostly going to be older folks, because remember, this is going to be your high risk folks. They're mostly unvaccinated.
So 65, 70 years and older.
Yeah. Yeah, they have a nice graphical abstract. We get a little bit more information here. We sort of break down different things like ER visits, going to see your doc, going to the urgent care. You can see some Kaplan-Meier curves over time. The big thing here, I think, is, we already knew that Paxlovid reduces your chance of death. We knew it reduces your chance of ending up in the hospital. But there was always kind of this discussion that we didn't want to say. Like, I remember you were saying last time, Vincent, that, when you had COVID, you started Paxlovid, by the next day you felt great. I had that same experience, right? I went to the ASTM&H conference. I took a risk. I came back. My throat was a little scratchy. I was about to go for a run. I don't know if I was going to record it on Strava or not. And I was like, I was at this big meeting. I should just probably check. And it was positive, and I started Paxlovid right away. By the next day, I had zero symptoms. Don't tell my wife, because I still spent 5 days working on the next textbook of parasitic disease, as a recluse, keeping her safe. There is all this sort of anecdotes of people starting Paxlovid and feeling better quicker. Here's actually some data. Here's some data that, it looks like that's the case. People feel better quicker when we start Paxlovid. So this is probably helpful, because we have docs out there. I don't know, people get Paxlovid and then they feel worse and they have rebound. The science is that people that take Paxlovid, they feel better quicker. And even if they have those issues during the second week, as we've discussed, a 90% reduction in the severity of those symptoms during the second week. So
this is a huge study, right?
Yep.
Thousands of patients. I remember I sent you yesterday some study saying there's no help in older hospitalized patients, but this contradicts that.
Well, if you look closely at that other study, and I really thought it was, not only was it a bad study, but the headlines were bad. So one of the things, if you look closely at that study, it said, early on, we were seeing an absolute reduction in, mortality and progression of 5%. Now the absolute reduction is only 1%. You still were seeing the reduction. They were just saying, like, when you've got a high risk population that, you're going to end up with, like, I don't know what the, let's say it's 20% of people early on were ending up in the hospital, and you reduce that 20%, you get an absolute reduction. They're saying now that people are vaccinated, they're not getting poisoned with hydroxychloroquine and ivermectin quite so much. Now maybe it's like 2% of people are going to end up going to the hospital. So you reduce that, so, it's the number needed to treat has grown, but Paxlovid still works.
Yeah. I mean, they were saying, the headline said it doesn't work at all, which is not correct. No. It does work. And so even though it may be reduced, you're still going to use it because you can still save lives. Yeah.
It's like airbags, are much more important when you're doing, 100 miles an hour on the Autobahn, but they're still pretty good at 55.
Yeah. Right.
All right. So Paxlovid, remdesivir, molnupiravir, convalescent plasma in certain circumstances. And then that second week, right, we can really reduce chances of folks ending up here with vaccines and all these other things we've talked about. But that second week is still when we are seeing folks in the hospital. We're still seeing the need in certain cases for steroids, anticoagulation, pulmonary support, remdesivir, and in some cases, immune modulation. All right, and I just have a few articles here in the last bit. So this first article, Interventions for Long COVID, a narrative review published in the Journal of General Internal Medicine. Now, this is behind a paywall. It's a little bit annoying, right? It took me I had to wait till finally I could access it through the Columbia site, and then I did. So I'll go through a little bit. So they start with comments, long COVID continues to impose a significant burden on COVID-19 survivors, presenting with diverse symptoms and clinical uncertainty. We have talked about the fact that now it's probably about 1% to 2% of folks after an acute COVID versus early on, it was 15 or 20 of people were still sick at 3 months. So that's much better, but it's still, 1% of hundreds of thousands of people getting infected all the time. So now the review looked at evidence from 97 studies, including 26 randomized controlled trials, 15 non-randomized comparative studies, looking at the effectiveness and comparativeness of different interventions. There's actually a nice table. And so I wish this wasn't behind a paywall, because it would be nice for clinicians and maybe patients to be able to look at some of these tables, some of the different things that were studied. Like they talked about that probiotic SIM01 study that we talked about, where they had certain effects on brain fog and fatigue. They talked about some of the vagal stimulation. They talked about some of the naltrexone studies. And they actually have, here's the intervention, here's the studies that we saw, here's what it showed. So it's a good paper for people to look at, but it's long, the tables stretch, and it's behind a paywall. So that's just, but I'll leave in a link. And we also have JAMA Network Open, the article COVID-19 Vaccination and Odds of Post-COVID-19 Condition Symptoms in Children aged 5 to 17. Case control study, 622 participants. And yes, vaccines were associated with a 57% decreased odds of one or more post-COVID conditions and a 73% decreased odds of two or more post-COVID conditions. So, people are always saying, I don't know, vaccines for the little kids. Yeah, I mean, this is the issue for the little kids. It's the post-COVID conditions. It's the months of not being able to get back to school. It's the months of headaches, fatigue, learning challenges. And we're seeing pretty good protection here with the vaccines. And, hey, I understand, because I don't know, mRNA vaccines in my children, maybe there's some misinformation here. But we've got Novavax, right? And Novavax is authorized for use in individuals 12 years of age and older. So chunk of these folks, you can go ahead, traditional protein-based vaccine. All right. And I will finish off, right? No one is safe until everyone is safe. And so I'm hoping, these are tough times. We're going to need your support. As we sort of suggested last time, we've gotten legal threats. People would like some of our science communicators to stop communicating. So we may need your support to keep doing what we're doing. We may need your support for lawyers, right, Vincent?
Mm-hmm.
And we're doing our Floating Doctors fundraiser, where February, March, and April, we're a third of the way in. We're going to do our fundraiser, hopefully to get up to a maximum donation of $20,000. And just a little update from on the ground there in Panama, where I'm heading in a couple weeks. Our clinic in La Sabana turned out to be a great opportunity, as we had an occupational therapist working with us who's able to give in-depth attention to multiple patients, particularly women needing pelvic floor training and older patients with bladder issues. I think this is nice. It's not about just doling out medicines. She also visited 2 young brothers with progressive muscle weakness, provided environmental adaptations and exercises that can help implement to improve their quality of life. We've got them connected to the hospital system for specialist intervention, and she'll continue consulting on these patients when she returns to the States. So that's this great thing about the connectivity, is even when people go, they can stay connected and keep helping these folks.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Louis writes, important, more detailed data about TB in Kansas City. The perspective would be important in characterizing what's happening there for listeners. These are data as of February 9th. The recent TB cases in Kansas City include both active TB and latent TB infections. As of January 31st, There are 67 confirmed active and 79 latent associated with the outbreak in Wyandotte and Johnson County. So 176 apparent infections. Active TB cases must be treated, while latent cases represent individuals infected with M. tuberculosis, but without illness or being contagious. They may be treated to prevent activation at a later date based on pretty clear clinical guidelines from CDC.
Excellent. Yeah, thank you for sending us this our way. I had a patient this weekend. I should follow up on the results here, but get the busy weekend covering a number of hospitals, get the call that Mr. So-and-so's sputum came back. The culture is now growing acid-fast bacilli. So, we're worried about, different mycobacterial species. So I go over and I talk to this gentleman. It turns up he grew up in Western Long Island, or Brooklyn, as my parents like to call it. And I told him, I said, hey, here's the result that came back. Are you familiar with tuberculosis? That's what people are concerned about here. He was very familiar. He said, yeah, when I was a kid, a lot of people had tuberculosis. His daughter was there. What, tuberculosis? Isn't that gone? Isn't that in the history books? And so it was entertaining for me to let him teach his daughter and son-in-law about tuberculosis. And yeah, that may have been a risk factor. This may have been an individual who now has some other things going on, and the immune system drops down, and you get infected 60 years before it stays latent and then can activate. Another thing that I worry about with all the measles in Texas is people will often end up losing their ability to contain tuberculosis if they're unvaccinated and get a measles infection. So,
yeah. Julie writes, I'm having trouble accessing PEMGARDA in New York City. I'm 66, have bronchiectasis, take azathioprine for myasthenia gravis. I always wear masks. I had 3 COVID vaccines. I forgot to mask when 2 men did work in my apartment in early December, got COVID. I had Paxlovid on hand and took it immediately. My symptoms were mild, but triggered a current flare of MG symptoms, which I'm trying to manage with my neurologist. My Columbia primary care doctor prescribed more Paxlovid to have on hand and also did an e-consult with respect to PEMGARDA. And basically there's a statement from Columbia Infectious Diseases, which said it would be reasonable to pursue pemivibart, but access has been limited. So try prime infusions for PEMGARDA. So she got through to prime, and they sent her back to the doc for a prescription, and the doc said, I'm going to request that you meet formally with ID to discuss the prescription. There are questions regarding efficacy, blah, blah, blah. 2 questions. Would you recommend PEMGARDA for someone in my position? And is the efficacy of PEMGARDA now in doubt?
So the efficacy is, I'm going to say it's not in doubt, but let's talk about what the data is. So when this was studied, there was a particular variant circulating at a time when it was studied. We'd have a 75% reduction in medically attended symptomatic COVID-19. So the data was good then. We don't necessarily, check it again. So I just to be full disclosure there. But yeah, what you're running into here is probably a doctor who's not familiar with PEMGARDA. They don't know how to write the script. It's every 3 months. They may not know the dose. They may not know the frequency. It's amazing how many hoops you're having to jump through here just to get access to a medication that has this indication. Great group of ID docs at Columbia. So when you do get in to see one of my colleagues, make sure you say hello.
All right, we had a lot of questions about measles vaccine boosters. Noam writes, I saw a post suggesting adults over 35 should get MMR and Tdap boosters giving falling vaccination coverage. Do you suggest this or other boosters for adults who believe they are vaccinated? Kids, only if you live in certain high-risk areas. Should you get your antibody checked before you do this?
It's interesting. We're not making this recommendation across the board. It is interesting. I have seen some recommendations like if you're in a high-risk area or you're going to a high-risk area, consider. We definitely do titers on healthcare workers who, interesting, are probably not as high risk as people living in these communities where we're having outbreaks. So we don't make that recommendation. There is the idea that if you've had measles, if you've got your MMR, that there's lifelong protection. But remember, a lot of the data came when we probably were still getting, boosted from exposure. So far, we're not making this recommendation. Now, the Tdap, that's a little different. We are having issues with pertussis. So you do want to, even though it's driven by the tetanus, you do want to periodically get that pertussis protection bumped up.
And Megan has a similar question. I saw a CBS report that said people born after 1957 but vaccinated for measles before 68 are at higher risk from a measles outbreak. Is this true? Is there anything I can do? Should I get a booster or check my titers?
So Megan, this is like a little subtlety window here. So the idea was before 1957, there was so much measles that like everyone born before 1957 probably got exposed, probably got infected. So they have like that, that survivor protection. But then we had a variation in the measles vaccine. I think we were only doing like a single shot. And so there actually were a few measles outbreaks. I remember my little brother was at Fort Collins, Colorado. He ended up like locked in his dorm. And there is this little window. So if you fall into that, you should go ahead and get that second MMR booster.
Daniel, I had measles as a kid, probably in the 60s, before the vaccine. It was awful. I was covered with the rash. It was really bad. And then I got vaccinated as soon as the vaccine came out. So I feel I'm good. I'm not doing anything.
Yeah, no, I would say like for you, that would be a perfect situation. And maybe a reminder to people, having me is miserable. I mean, these kids, like I've been in areas where like kids are dying of malaria and they stop eating and they're listless. But oh my gosh, the kid with measles stands out. They're so miserable and they're fussing and they're crying and it is just crummy.
I mean, I had this one huge blister on my belly. I remember I watched it every day. Everything else went away. It was still there. I still have a scar from it today.
Yeah. Oh, their noses are running. Their eyes are red. Everything hurts. Yeah, it's miserable.
All right. This is unfortunately redundant, but Lisa was born in 1961. Should she get a measles vaccine?
Yeah. So she falls right into that kind of window. So born after 1957. But actually, let's see. Yeah. And then if you were vaccinated before 1968, so sort of, those are kind of your things. And, talk to your doctor about this stuff. I mean, I think that's one of the things I feel sort of too bad about where medicine has gone. But, this idea you come in, what's your diagnosis? I mean, it's too bad that we haven't created a better opportunity for people just to schedule an appointment with, hey, doc, I just want to talk about my vaccines and am I up to date and should I get any boosters? And I have questions. Because if we don't create an opportunity as MDs, as DOs, as other clinical providers of having these discussions, don't worry, there's some snake oil salesmen out there ready to have that conversation. And they're not actually going to feel like they're going to let the truth stand in the way of their good story.
So the second dose was recommended in 1989. So I don't know where this 68 comes from, 1968. Do you understand?
I think there was a change in the vaccine, and with the update in the vaccine, then it became a 2-dose, and before that it was a single dose. And this is this whole discussion, and we should probably have like an episode of this, where it was like when we made that change, was it a good idea to make that change? We have just stuck with the original one. But there are issues, right? We talk about this, that very rarely will people have issues with measles vaccination. Like you might have a couple febrile seizures per 100,000 kids vaccinated. And some kids will actually get a rash after the measles vaccination. There are some, when they make the choice. The current one as a 2-shot series, I think is great. The earlier one that was a 1-shot series, I believe, if I get this all right.
All right. Last one. Abdul Aziz writes, I took the meningococcal polysaccharide vaccine, ACYW, for my next Umrah. Do I also need the meningococcal B vaccine?
Yes. So you got all those letters there. You got A, C, Y, W. You're missing B, and B is something we worry about for people heading to the Middle East for Umrah.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.